there is a small subset of patients, maybe 5% or so, maybe 10, it depends on the series, where there's a flare, where even though they're having resistance, there are still cancer cells that are dependent on that EGFR. Because of the mutation, they're sort of constitutively active, and they're still suppressed because of the EGFR. So even though there are other cell clones that are growing, there are still a subset which are being suppressed by the EGFR TKI. And when you stop it, those cells start to grow rapidly, and patients become symptomatic rapidly. So again, it's a small subset, and you know them because within a few days of stopping the drug, they feel terrible. So for that subset, continuing the chemotherapy along with continuing the EGFR TKI along with the chemotherapy is something that we all do in practice. Again, it's kind of small numbers, and so that's part of the group where they were getting the osimertinib chemotherapy. The other one is a patient who is on osimertinib and have good control of their brain disease, but are starting to progress in the body. And so that's where, in our practice, where that's been done the most, is a patient who's doing well on osimertinib, who had initially had symptomatic brain metastases. Those are still controlled, but they're having growth elsewhere. So again, it's kind of different clones. Then we'll add the chemotherapy. And so our poster was really just showing that when you combine the two, it's actually relatively safe. With osimertinib, as opposed to the other EGFR TKIs, you do end up with cytopenia. So neutropenia, thrombocytopenia can be seen, and so the concern was that would not pair well with chemotherapy. And in practice, actually, the toxicity was reasonable. Now, this is not to say that people should be doing this routinely. We're not advocating that osimertinib plus chemotherapy together is the right approach, but it is now something that's going to be looked at further in clinical trials.